Surgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Merrill Hernia Portfolio. ITAC A, Apsimesh, Merigro Mesh, Filaprop Mesh, Filaprop Mesh Soft, Meridian Mesh, Profound N, Profound A, Monic Trocars, Eliaro Trocars, Eliaro Bladeless Trocars, Mesic Energy Device, Mesic Compact Ultrasonic, Mesic Ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create more to life.
Good evening, everybody. This is Dr. Kalpesh Jani, the President of Amasi, and we welcome you once more to another edition of Amasi CME. Continuing our tradition, I think we are going to again have a very interesting and a very lively talk, as well as a discussion followed after the talk. We have got a very eminent speakers and equally eminent moderators. So we hope for a very interactive sessions. We also, the audience are logging in through another portal. They've got another link, and we'll be watching the chat box for post your questions. We request the audience to keep on posting their questions, and the moderators will carry on the discussion along with Dr. Ramana. I'll just hand over now to our Zonal Vice President, North Zonal Vice President, Dr. Rajendra Mandya, to introduce the moderators, and after that, Radip can take over. Dr. Mandya, over to you.
Thank you. Good evening and welcome to everyone. It is my pleasure to introduce our distinguished moderators. Our first moderator is Dr. Girion Lil. Dr. Lil is a highly respected hernia specialist from Germany with the extensive expertise in the abdominal wall reconstruction and minimal invasive hernia repair. Dr. Lil has contributed significantly to advancing laparoscopic and the robotic techniques. His international perspective will provide the valuable insights into how the hernia management strategies are evolving worldwide. Our second moderator, Dr. Sarfraz Beg, he is a renowned bariatric and minimal access surgeon from Calcutta. Dr. Beg has a special interest in the complex hernia repair and abdominal wall reconstruction, particularly in patients with the obesity and metabolic disorders. His expertise in integrating the bariatric surgery with the hernia management will add a crucial dimension to our discussion today. Our third moderator is Dr. Vivek Bindal. Dr. Bindal is a well-known laparoscopic and robotic surgeon based from Delhi. Dr. Bindal has been actively involved in advancing robotic hernia repair techniques, and his research has the focus on improving the surgical precision and patient recovery. His insights into the robotic assisted abdominal wall reconstruction will be invaluable to our conversation. Our fourth moderator is Dr. Yusuf Afaq. Dr. Afaq is a skilled minimal access and GI surgeon from Aligarh. Dr. Afaq brings a strong clinical and academic backgrounds in complex hernia repair and advanced laparoscopic surgery. Over to Rajdeep to introduce our today's speaker. Thank you.
Thank you very much, Dr. Mandya. And with the galaxy of very important and famous moderators, I would say we have a much more famous speaker. How do I introduce a speaker who everybody knows about in India? So, well, I'll just try my best. Dr. Balasubramaniam Ramana, he has more than 3 decades experience in minimal access surgery, and he has operated on everything minimal access, esophagus, stomach, pancreas, biliary, colorectal, and he's even thyroid, parathyroid, urology, and previously gynec also. He is the president of the International Bariatric Club, Asia Pacific region, and also the chairman of the IBC Academy. He's the founder president of AWR Surgeons Community, a group which has really revolutionized hernia surgery in India. He has been the director and head of Department of Minimal Access at CMRI, CK Birla Hospital, Kolkata. He has also been at Bellevue Clinic in Kolkata. He visits Sir Gangaram Hospital in New Delhi, all very big hospitals in these cities. And currently, he has moved to Australia. He's a staff surgeon at Shepparton, Victoria, Australia. But he continues to help the Indian surgeons in all aspects of advanced hernia surgery. He has traveled extensively across India in all the major cities, big and small, to help the surgeons for minimal access as well as complex hernia surgeries. He's truly a pioneer in the field of AWR in India, and he is also the part of the first global group of surgeons who published the results of ETEP retromuscular repair. And in fact, he was the one who introduced STAR to India. So he has a number of affiliations: the European Hernia Society, American Hernia Society, SAGES, British Hernia Society, American College of Surgeons, and many, many other. There are more than 10 affiliations here. And on a personal note, on behalf of the association, I'm particularly thankful to him because it is 1:30 a.m. in Australia, Victoria, Australia right now. And he's been up the whole night just for this talk. Thank you very much, Dr. Ramana, and over to you.
Thank you very much, Rajdeep, Kalpesh, and everybody. I think I'm giving a talk after a while, so I'm feeling very nervous. So anyway, it's, I think, good to get on to the subject matter in hand. And I hope you can see my screen moving. So this is the title of the talk. Rajdeep, do let me know if the screen is moving.
Yeah, all is fine. Audio, video.
Thank you very much, Rajdeep, for giving an outline of my previous life. So I'm in Australia. It's a new life here, and I'm just a humble surgeon working in private, public, and going to private soon. So this is a beautiful part of the world. My disclosures are, I'm very strongly invested in the well-being of members of the AWR surgeons community and the ANZ hernia group as well. This talk will leave a little evidence of history, but little history of evidence. My aim is primarily to discuss ideas. Now, ideas are very well illustrated when we talk about mankind's most crucial disease. Now, this is a disease which has oppressed men and women for centuries. You must be wondering what that disease is, and that disease is erectile dysfunction, male erectile dysfunction. Now, brilliant ideas, have they really worked in the field of erectile dysfunction? It's a very, very illustrative example when we go to history. So, because dogs have vigorous sexual activity, visible sexual activity, people prepared testicular extract injections from dogs to treat impotence. They tried it with sheep. They tried it from monkeys. And when the century turned in 1902, because there was already some awareness that dysfunction, erectile dysfunction, may be because of venous leak, dorsal penile vein ligation was proposed as a treatment. So if you prevent the backflow of blood, the penis will become turgid with blood. And because you need more stiffness to suture the fascia, the buccal fascia of the penis, and plicate it, seemed to be a great idea. Now, Lightstone in 1908 said, let us resect all the penile veins so there's no blood going back out of the penis. And so the penis will become turgid and it'll help the patient with his problem. So he said that half my patients are permanently cured and the rest are improved. No problems, no complications. When people protested and said, no, this doesn't sound right, this is what he said. All scientific reason falls flat against the absolute of a flaccid penis. So this is how he approached the subject of erectile dysfunction. So bad ideas have always comprised our entire history in the field of medicine and surgery. Now, another beautiful illustration that in 1831, a man called Preston published in the New England Journal of Medicine that if you ligate the carotid artery for a stroke, and hemorrhagic stroke used to be pretty common, then because you're addressing the source of blood flow, the stroke gets corrected and you become fine. I mean, the stroke doesn't progress and you recover. And the first patient started walking in a day or two, and Preston started doing more cases. And because it seemed to be working, he said, if it is working, we can do it even better. So he ligated both the carotid arteries to double the benefits of this procedure. And you can guess where that went. But my talk has nothing to do with erectile impotence or stroke. My talk is a new paradigm in giant hernia management. So why I'm talking about this? Because a paradigm is basically, the word means it's an ideal, an example, a prototype, a model, a standard. Now, paradigms in surgery, let's illustrate a few of them, like the advent of ether anesthesia. Changed the world, right? Same. Sterilization started off with carbolic acid. Cautery has revolutionized the way we work. Even we can say that laparoscopy has changed the way we work, the use of mesh in hernia surgery, and so on. But the thing about paradigms is that they shift, and they shift when new ideas come in. So this is a very, very fundamental part of how the human species works in the field of science. So new ideas generally are greeted in a rather unique way if we go by history. Now, Robert Liston is now famous in internet as the man who in the 19th century used to be known as the fastest hand in the Western world, used to do a below-knee amputation in an awake patient in 30 seconds. So this is a classic picture where he slashes with his sharp knife and cuts off the leg of the patient, the fingers of his assistant, and what happens is the patient dies of bleeding, the assistant dies of infection, and a member of the audience in the theater died of shock. So the first documented case of a 300% operative mortality. So Robert Liston said, anesthesia, ether anesthesia, unnecessary luxury, a Yankee Dodge, that's what he called it. So Werner Forsman is another example. In 1929, he was an intern in cardiology. He was very keen on cardiology in the city of Heidelberg in Germany. So he said that, okay, we know that the upper limb veins drain into the right heart. Now, what if I pass in a catheter or some kind of tube through the cephalic vein into the right heart? It will go into the right heart. And if we take an X-ray, we should be able to see it. His boss strictly forbid him from doing so. He said, we cannot do anything like this, and you will not do it. So what he did was, off hours, he sneaked into the theater, and with the help of his nurse, he passed it on himself and then went to the X-ray department and took this picture. He lost his job, and he was so badly treated that he left cardiology and went into urology. Now, this was 1929. In many, many years, around 1955, he received a call saying that I'm calling from Stockholm. Some sound. Yes, sorry. Thank you. So somebody from Stockholm said, we're giving you the Nobel Prize. And he kept the phone down, thinking it was the local version of the Nigerian prince. But somehow they managed to connect, and then the rest is history. He got the Nobel Prize for having changed the field of cardiac medicine and surgery with that one idea. Now, paradigms shift. But if your paradigms don't shift, you are possessed of dogma. Now, because we get wedged into positions, lap or open, or lap or robot, or IPOM and ETEP, we take strict positions and we keep defending them. We are actually all victims of dogma, rigid ideas. So to come back to the other aspect of my talk, which is giant hernia. So what exactly is a giant hernia? So this is basically a condition which everyone uniformly thinks, oh, it's a loss of domain hernia. Well, it is, but it could also be more than that. So Henneford has published, amongst a couple of other people, and defined what giant hernia is: a defect width more than 15 centimeter or a defect area of 150 square centimeters. The French have opined that a Tanaka index of more than 30 is giant hernia, etc. Now, the European Hernia Society, you know how they classify incisional hernias, especially the midline incisional hernias, where the widest hernia is W3, which is more than 10 centimeters. Now, my idea is the W staging is very archaic, and it's high time we go beyond the EHS paper. So if you look at W3, and if you listen to me, I would say 10 to 15 centimeters is a big hernia. It's a W3 hernia. It's not really that big for those of us who do this kind of operation. But any bigger, let's call it W4. A is 15 to 25 and B is more than 25 centimeters. So this is a hypothesis, and this is being tested with data as we speak. So W4, ladies and gentlemen, is potentially a new paradigm and could change our perspectives of management, because you can't treat a 10 centimeter, 12 centimeter hernia as the same as a 32 centimeter or 27 centimeter hernia. It just doesn't make sense. Now, with W4 hernias, we do have giant problems, and you're well aware. Now, as far as recurrence is concerned, Theo Bisgard published more than 10 years back that the recurrences may be as high as 50%. So recently, the Cleveland group published a 46% composite recurrence in bridged TARS. So if you're unable to close the midline, the recurrence may be nearly half your patients. Now, before we proceed, once again, I'll take you a couple of steps back and go into the history of giant hernia management. And we all know that it started with Ramirez in 1990, right? Not really. If you talk to Jan Kukleta of Switzerland, he is a repository of history knowledge. So he talks about J.B. Flamen, J.C. Mayagoitia, Carbonell Tate, and then when you actually scratch under the surface, you get some fascinating information, like this book by Carbonell Tate called Eventrationes, where you can see fascinating pictures like this. Now, of course, we've worked together and we've written a little bit on the history of retromuscular repairs, and I think it will make for interesting reading for you. So the Latin Americans have been above the rest of us for a very long time. And Goni Moreno in the 1940s spoke about the treatment of giant hernias with pneumoperitoneum. And then Albanese was an Argentinian surgeon in Buenos Aires who actually has played a pivotal role in the development of the field in the entire South American continent. So he has done a lot of complex releases and taught surgeons across decades. He died when he was, I think, 105 years old age. And he's taught all his life and advanced the field in a huge way. In the northern part of that continent, Todd Henneford has again played a very transformative role, and he has basically been an influencer without the use of social media. And his lineage has been pretty much a who's who of hernia surgery who are considered the top experts in the field today. Apart from that, Hanniford has developed a lot of other things, including the SEDAR app, his focus on outcomes and excellence and artificial intelligence more recently. He has defined the open preperitoneal repair, which I call as the Hanniford repair. I think we owe it to him to say that. His fellow, Yuri Novitsky, changed the field of surgery, the hernia surgery, in 2012 with this publication, which you know well about. So this is, again, a sort of a mini paradigm in the field of hernia surgery. And along with Novitsky, social media and real life have been the platforms for a variety of top experts who come from that same stable, and they have been changing the ideas and guiding us in a specific direction in the management of abdominal wall complexities. As a result of which, we are doing more TARs, more polyparastomal repairs, and more robotic ETEPs. And as you would agree, we are having an exponential increase in complex operations for simple hernias, though that probably has not been the motive behind any of them. Now, Mazen Al-Mansour published this recently from the American ACS data, which basically showed that even for the management of hernias up to 6 centimeters in size, there's been a huge leap in the number of complex and advanced procedures for these for these hernias. And you had like a 13-14% TAR incidence for hernias smaller than 6 centimeters, which you would agree is a little extreme. And if you ask experts today, most likely they would consider robotic TAR as a gold standard for the management of many or most hernias. Again, to take you back a few more years, in Western Europe, in the pretty Swiss city of Basel, and almost around the same time in Cologne, people like Dietmar Eucker and Gerion Lill started working on a new concept. So the credit for this goes to Eucker, who developed an abdominal wall traction system, which he called the AVEX system. And subsequently, post-publication and working on more cases, and Gerion Lill developing the device formally and founding the company of Fasciotens, the collaboration between these two pioneers started. And this is something which would be a landmark in hernia history. So the premise of fascial traction is that facial closure is a critical factor in outcomes. We all would agree, if you don't close, you have complications, wound infections, dehiscences, and recurrences. And the premise is basically the lateral muscles are stiff and thickened and contracted. So if you release the muscles by component separation, then you're able to close it or have a better chance at closure, but it has its own morbidities and complications. And if you can avoid complications, then it is better for the patient. So in 2024, how do surgeons handle giant ventral hernias? So this is 2025, but you get the point. So it's one of a variety of procedures, which basically depends on the scope of the practice and expertise and training of the individual surgeon. But these are kind of more or less the mainstream procedures, which most experts would say. The problems with the TAR is that the recurrence is no longer uniformly considered to be 2 to 5%, but probably much higher recurrence rates if what data seems to be coming is accurate. Now, from the Cleveland Clinic, 1/3 of patients may have a recurrence in 6 years' time. So obviously, it brings us to a very disturbing thought, what to do about these patients. So it's really not that easy to manage these patients if they come back with a recurrence. So my approach to giant incisional hernias is basically to spend more time on preoperative preparations and identify the problems and reduce the risks so that we can improve the outcomes. My operative approach is not robot or laparoscopic approach for these hernias. It is only open. I'm not talking about your Mickey Mouse hernias. I'm talking about giant incisional hernias. My operative principles include an extraperitoneal approach, close the defect somehow, and put in a giant Stopa type GPRVS, the great prosthesis for the reinforcement of the visceral sac. And for closure, because just a preperitoneal dissection doesn't allow you to close giant defects, I would use fasciotens to pull the abdominal wall together and close it. So this is an example of a complex incisional hernia, recurrent incisional hernia in a male patient. And you can see the edges of the defect are so far apart. And obviously, it is going to be, especially with loss of tissue, it's going to be a problem for anyone. So this is how we do the preperitoneal dissection. You can see that it is delicate. You have to use a combination of blunt and sharp techniques and peel off the peritoneum. Just fast forward it to save time, and you can see that the peritoneal sac is being taken out slowly. And of course, you would have areas which are more difficult. So this is where we are going under the diaphragm, and you can see the vertical fibers of the diaphragm there. And we can again use blunt or sharp or using diathermy to create the planes. And some would be easier, some would be harder. That is how it goes. And this is closing the peritoneal holes or tears. And that is, of course, an important part of the operation. And then you put in a giant mesh and you tailor it accordingly, and then you put it in. Right? So that is the use of the mesh, and then we cover it with packs like that. And through this dissection, we can reach the same planes like you would do in a TAR. So I'm putting my hand in the subxiphoid area, coming on top of the retroperitoneum, on top of the psoas and quadratus muscles, and coming out through the space of Retzius without opening the peritoneum. So that's pretty remarkable plane. And this is another example of full exposure of the central tendon of diaphragm. And this is without doing a TAR. So you can actually do the entire preperitoneal dissection without dividing the transversus muscle. And if you look at that patient that I showed, we hooked that patient up after preperitoneal dissection to the facial traction device, fasciotens, and within 2-3 minutes, you can see the edges have come together effortlessly. It is pretty incredible and gratifying to have that kind of situation, that change in operative findings. And this is another patient post-liver transplant. You can see this is a very complex and incredibly massive defect. And the measurement in the horizontal axis is around 32 centimeters. You can see that. That is 30, and then another couple of centimeters over there. That's 32 centimeters. And you can pretty much appreciate that there's no way in hell you're going to close a 32 centimeter defect with component separation of any kind. I mean, it's just not happening, right? It's incredibly difficult to close a 32 centimeter defect. Now, this is after the dissection, placing the mesh and taking the facial traction sutures. And this was after full 30 minutes of traction. you can see that we have managed to reduce the gap to around 15 centimeters, right? Which still is a big difference in the between the edges, but we now have the job of closing it with sutures. So this still looks very formidable to close. So if you use appropriate suturing techniques to close the fascia, you can still do a much better job purely based on the technique. So we actually managed to close it bar a small island. So pretty much we managed to achieve what was incredible to me. I never expected to be able to close it. Now, this is that same patient. You can see this is post-liver transplant recurrent incisional hernia, and this is 32 centimeters to start with, and this looks pretty solid. And obviously, we are concerned about function and bulging and all of that. And you can see that the patient is able to get off the bed straight. I just stopped him from doing so. This was only a few weeks. And this patient has been on follow-up for what now, 2 or 3 years probably, and still going very well. So the advantages of the Hanniford operation are you avoid the problems of TAR while you're still able to achieve the whole, the frontiers of the extraperitoneal space. And you can reach over 90% closure rates without doing component separations. So what actually is the emerging fasciotense story? What are the numbers like? So basically, I think nearly 2,500 procedures, probably somewhere close to that, have been done so far, and the numbers are increasing. The recurrence rates for these procedures is pretty decent, and facial closure is more often than not. So more than 90% is the facial closure rates. So, ladies and gentlemen, the changing paradigms in the giant hernia management is for you to think beyond TAR or beyond ACST. Because when you follow up your patients, you realize that it's not as rosy as you thought. And that makes you think harder. And it is well possible that a new paradigm, a new standard, could be an open preperitoneal ventral hernia repair with fasciotense. The Europeans do not do the Hanniford operation much. They prefer to do the Reeve Stopa and use a narrow midline mesh extending from the edge of one rectus to the other, which is also, I think, a fair approach for many of these hernias. Hanniford published over 1,000 patients. So I think we have pretty good evidence from that perspective of the preperitoneal approach. Now, what about fasciotense? Henning Niebuhr has published a lot of these cases based out of Berlin, Germany. He's closed defects as much as 44%. Some of these patients he has done TAR. All of us do TAR when we push to the wall, but it's not a routine anymore. So the facial closure rates are excellent, and compartment syndrome and mortality are very rare. Now, at this point, I would like to take you on a side journey into how science and practice evolves. Now, there is a theoretical model proposed by Thomas Kuhn, who is a scientist who has dealt with the history and philosophy of science and medicine. So there's something called a Kuhn cycle, and you'll bear with me for a minute, and I promise you, you won't be disappointed. So normal science is just regular stuff that we all do, whether it's using a mobile phone or driving a car. It's nothing that you even think of, right? It's normal science. But in the process of the daily life, sometimes you realize that there are variations in what you expect, right? So your phone is hanging, or your computer is not that fast and it's crashing, or something similar, right? So then you notice that, these are the things which are not really in the syllabus, not what we thought would happen. And when enough evidence accumulates on such variations, then you have like a full-blown model crisis. Oh shit, this isn't working. So there's something wrong with this model that we have thought to be inviolable truth. And then one day there's a revolution, and somebody comes up with an outrageous brand new idea or a device or technique, something which completely goes off tangent, right? And that changes the thinking of everyone else. And people start saying, okay, let's try this. This seems to be good. Let's work on this. And when that happens, the Kuhn cycle is completed and the new paradigm becomes the normal science, the boring, everyday normal science. Now, what does this have to do with hernia surgery? Now, I will show you how the Kuhn cycle has evolved in the 1990s to 2017. So normal science was IPOM for life. I don't know about you, but in the 90s, I believed, I drank the Kool-Aid. I used to put in 30 by 30 Gore-Tex meshes in massive hernias. And I used to believe that I'm doing the best hernia operation in the whole world. And that is what was normal when we bought the marketing Kool-Aid. Then over the years, we started seeing recurrences. Patients were having a lot of pain, and we used to blame them. Oh, you're too much of a sissy. Don't complain. You're not supposed to complain. This is a painless operation. This is a fantastic modern operation. And we used to see these model drift cases. And suddenly, I think enough experts started talking about it to for us to realize that, oh, this is actually something which we shouldn't be doing. Maybe we start questioning what we have been doing. So this is like a full-blown model crisis. And then a revolution like a TAR or an ETAP or a TAP, whatever it is, let's not put the mesh in the peritoneal cavity. Let's not keep defects open. And then the paradigm changes and everybody says, oh yeah, let's do this. This is exciting. So 2014 to 2017, people have done that, a lot of TARs, and we started doing the ETEPs, and we did our bit to complete the Kuhn cycle till 2017. Now, from 2017 to the current times, what is the normal practice? Look at your own practice or that of your friends. We're doing ETAPs, TARs, and RTAPs, and we realize that maybe experts should do it. It's not that simple. There are complications, there are disasters which are happening, and this should be better actually. So let's actually focus on preoperative weight loss, Botox. Let's use adjuncts to surgical technique. Let's use fasciotens, or let's not do a TAR for everybody. Let's do a Reeve Stopa. And the paradigm is changing. So now we are in that cusp where paradigm of management of these hernias is changing. And this is, in my opinion, the current Kuhn cycle. Ladies and gentlemen, my philosophy as a surgeon is to question and never stop doing that. And I would say, let the facts change. Don't hold on to those facts which you accept as the holy grail in anything that you believe in. So you accept being wrong and you embrace change. Old paradigms should die. Don't be loyal to them. Be awake for new ones which are evolving. And so you owe it to yourself and to your practice and commit to evolution. So evolve as a surgeon. So the interesting thing about evolution is that though it is a slow process, revolution is what leads to evolution, especially in the field of medicine and surgery. And I think one of the key qualities for a modern surgeon is curiosity, and it is the new superpower. If you look at the top experts in the world, they all possess this quality. They're very curious to find out how things can develop and how things can make patient outcomes better. So if you have more curiosity in the field of abdominal wall and hernias overall, new techniques, technology, and experiences of all kinds of people across the world, the Deep Impact Surge Conference in Chennai brings you almost 30 global and national societies in action who are actually running sessions by top experts in the whole world. And it's as if you have individual world body meetings running in different sessions in different rooms. So it gives you, it's like a food festival of hernias. So I would very, very warmly welcome you to join us and satiate the curiosity that you may have for hernia surgery. Thank you very much for your patience, and I think I'll stop sharing the screen.
Fantastic, Dr. Ramana. We always are engrossed whenever you talk about the topics you are really interested in. So I won't take much time from the moderators. Maybe we'll start with Dr. Yusuf for his comments and his experience, his thoughts.
Yeah, thanks, Ramana. Overall, nice talk. And I would have liked that you should have mentioned peritoneal flap also as a new paradigm shift, something new like peritoneal repair and fasciotense and something new in the box, which has a lot of potential in the future also. And as we are doing a lot of peritoneal flap, we are combining with TAR. We have even combined with anterior component separation technique, and we see a lot of potential in it.
Well, I did mention it as one of the procedures which are nowadays done by modern day AWR surgeons, but I wouldn't go so far as to say it's a paradigm shift. I would say it's a very nice technique which is appropriate in many of these situations, as people like you would vouch for. Yes.
Thank you.
So, Dr. Yusuf, regarding the peritoneal flap, would you be able to close such big hernias like 30, 40 centimeter defects?
Actually, we use peritoneal flap and we combine with another component separation technique. So we get benefit of two component separation technique. The peritoneal flap is also using extra tissue and is a type of component separation technique. And when we combine with TAR, so there are benefits of TAR and peritoneal flap. I personally combined peritoneal flap with anterior component separation technique also. So the benefits of anterior component separation technique combined with peritoneal flap. So to make we have almost all the cases we have closed large hernia even without going perioperative Botox and all that.
So this is the interesting and, to my mind, ironic part of what we do. So when we combine these things, one view is you're getting the best of both worlds. The other view is you're getting the worst of both worlds. So which is true is really hard to answer on a given point, isn't it?
As TAR and anterior component separation, people say that dividing too many muscles will make the abdominal wall dynamics
No,
unstable.
I did
But
not mean that. I did not
yeah,
mean that.
but peritoneal
It
flap,
was just an
yeah,
aside.
yeah. Peritoneal flap,
Technically.
we are not dividing any muscle, so it is not destroying any lateral muscle, actually.
So, Dr. Ramana, what about, say, transverse incision, transverse hernias like L1 hernia, large hernia with loss of domain? Would facial traction be helpful there also?
Yes, I believe so. It definitely works, and the direction may be different because the dynamics in the lateral abdominal wall are different because you've got the ribs above and the iliac crest below. And so I would say that we should pull in the cephalocaudal direction and not from the right and left directions. So yes, definitely.
Yeah.
Wonderful talk, Dr. Ramana, and really enjoyed, I think, the way you took everyone from erectile dysfunction to the loss of domain
Got your
hernia.
interest, didn't I?
And the sort of, that's what created interest. That's why we actually sat through the talk.
Your volume is a little low, mate.
Talking about the history and putting it in perspective is something very, very important, and not important, but important. But it's I think it is also very useful to learn that what we are doing today will be obsolete tomorrow, whatever we may do. There would be methods, and that's why it's a totally evolving field. Uh, what Girion and Yoker have developed is a wonderful device which has been helping a lot of patients and has a potential to help a lot more. Uh, there are, always few concerns when we talk about uh, facial traction. Facial traction device, facial tense, and has been made in a very simple, replicable way, so it can be taken up very easily by a surgeon. I would say it is one of the most simple abdominal wall reconstruction techniques, technically speaking. But what about the coverage of mesh? You are not doing a component separation. You are just doing a reef stopa dissection. So your mesh can be from a linea to another linea. Now this patient had a stoma. This patient had lateral weakness. Uh, you say you will go pre-peritoneally, which you may be able to do. Most of the surgeons will not be able to do that. And then you say don't do a TAR, go pre-peritoneal. It looks, you know, it looks something which cannot be replicated by majority of people. So what's your take on that?
Yeah, I do agree that it has its own hurdles, the preperitoneal technique, but so does TAR. And this is the important thing for many people to realize, that just because you see edited videos of TAR looking very nice and clean, and the retrorectus plane is so easy to develop till the lateral part of it. After that, it's anybody's guess where that plane is going to go. So you really need to draw out a nuanced appreciation of the changing anatomy of that transition zone. And that is not very easy, especially in redo cases. So you know all of this. So the thing is, this is a difficult set of operations. This is a difficult plane or set of planes. And it's never going to be simple, which is why I would say that if you have to do complex stuff, you should be neck deep in it. It's not for those who are just trying out a little bit. This is not really the field to try out. This is like me saying that, okay, I'm going to do portal vein resection, extended Whipples, but I've never done one in the last 5 years. And so it's not something that anyone would advise me to do, right? So it's kind of like the same thing, though you may be an expert in doing many other kinds of hernias. When we are talking about giant incisional hernias, we should accept that it is truly the domain for an expert. It is not the domain for somebody who just does a variety of hernias and also thinks he can do this, he or she. So I would say, yes, the preperitoneal plane may be difficult to get for those who are not really experienced in that. And a reef stopa may be a good option. And if you just think of it, if it's a midline defect, how does dividing the transversus abdominis and going laterally, how does that help? This is a question which, all these German and European experts who use fasciotens would say that if you can close the defect, what's wrong with reef stopa? I don't need to take the mesh further down because it's not a lateral recurrence. It's going to be a midline recurrence anyways. So that is their approach. And I think, sorry?
Sorry. The question would come mostly in the cases which have a lateral incision or a hernia.
Yes.
And
Agreed.
in your philosophy, if there is an incision laterally without a hernia, would you want to cover that in such kind of a repair?
Exactly. So I would think that I want the GPRVS. I prefer the stopa rather than the reeves. So I prefer the preperitoneal for that exact reason. Drain site hernias, stoma closure hernias, and all these lateral incisional hernias can also be taken care of, even if they are minor at that point of time, you think. And but to answer that question finally, to complete that answer, if you have some weakness laterally, you could actually divide the transverses closer to the midline and sneak underneath it, pull it and sneak underneath it and go below and behind the linea semilunaris, what we call the Madrid modification of TAR.
Right. Dr. Beg, Girion.
Dr. Vivek Bindal, I believe you are the first one who has experience of fasciotens with robotic approach to hernia. So what is your experience on it?
Yeah, so I think Girion was there in the theater when we used it, and we basically uh, did it for a few complex hernias. So it was, uh, fasciotens was always a tool for open surgery in our eyes. And when we thought about using it in robotic, it was kind of, in minimally invasive environment, it was a puzzle, but it happened very smoothly, and I don't think so. As I said, it is a simple thing to uh, to replicate. It does require some time and training to put those sutures in on the edges of the mesh. So we have done it in ETAP technique mostly, and what we do is after the restopa dissection for W3 hernias, more than 10 centimeter hernias, most of the minimally invasive surgeons would have to do a component separation to close the posterior and the anterior uh, sheaths. Now, with fasciotens, after the restopa dissection, we can put in 5 to 6 sutures on each side of the defect, take it out, crisscross on the other side, and put a facial traction device up there. And that, in the cases we have done, has reduced both the anterior as well as the posterior defects and enabled us to do a closure without a component separation in recurrent hernias up to 15 centimeter size in minimally invasive environment, both laparoscopic and robotic. So that actually I think gives a lot of advantage, and it is just like those transfacial needles which we have been using for IPOMs can be used, or the loops can be used to bring out those features of fasciotens. And so it's not difficult. It is replicable, and it allows MIS advantage to a lot of patients who otherwise would end up with open surgery or would end up with component separation. So
Yeah. Thanks, Vivek. Dr. Sarfraz Beg, some tough questions from Dr.
No,
Ramana.
not at all. There's only one thing better in life than intellectual discussion. It's called good sleep. So at 2 o'clock in the morning, you have to leave our friend for good sleep. So, but a very, very interesting and very powerful talk, which was expected. I'm glad I was, listening all throughout. And it is fascinating that there's a new tool in the toolbox. I also feel convinced that this is working. It surprises me how it works because, like Ramana showed about a big hernia, which was the lateral muscles are so contracted. So I would probably put it as a question rather than as a comment that how does it actually work? How does 6 centimeter contracted lateral muscle become so big that it can cover up a 30 centimeter defect? There has to be some uh, better explanation than just stretching because the botulinum toxin is not able to achieve it. I'm sure there are probably animal experiments that I'm not aware of, or there's probably some other experiments that I'm not aware of, but I would really like to know that answer. And the second thing is just a comment because I don't want to take too much of your time now. And that is, uh, uh, everything lasts for some time and it sort of is disappearing from the hernia world. And I think the best thing to do is like Tilopa, be open to everything and attached to nothing. And it's not a great idea for hernia surgeons to throw away the baby with the bathwater. It's best to keep all the tools and to use them sensibly in each case. Every case seems to be different. The more we dwell in the hernia world, you realize each case can merit with some procedure which may look obsolete. It may also look stupid, absurd, but it works like peritoneal flap. Uh, and so, there are so many things that's happening out there, but I totally agree that fascial traction works. But I want to know from you, why do you think it works?
Well, I think our understanding is still nascent. At least my understanding certainly is. On a structural level, while on a gross level, there is greater compliance. The patient is usually treated with Botox preoperatively, which does lengthen and thin out the muscles. And during anesthesia, the muscles are paralyzed. And it's important to have a deep plane of anesthesia during the operation. And then the traction is graduated and sustained. And over that period of time, it does manage to stretch the muscles on either side. Now, on a structural microscopic level, I think it has to do with the physical force of pulling the myofibrils uh, further apart and lengthen them. But Again, this is probably above my pay grade, and I would just defer to those who would know more about it. At this point of time, I think that is all we know. Now, regarding using old techniques and not throwing out the baby and bathwater, I totally not only agree, but I vehemently support that approach. Now, think of it. We are talking of colonizing Mars, but we are still putting pieces of plastic inside patients' bodies in 2025. Pieces of plastic. And that isn't modern science. That is primitive science. That is plastic. And we're still doing it. We're still doing these procedures like peritoneal flap or ACST or TAR, whatever it is. So basically, the experienced AWR surgeon is one who has a lot of tools in his toolbox. So the bigger the toolbox, the more capacitized you are to handle these subjective variations in the clinical cases that you get and the problems that you face on a daily basis. So yes, absolutely agree with that.
So Girion, can you answer that, what the basis could be for the lengthening we achieve with FT?
That would be great. I'd be happy, but I can't really. I thought it all starts with the genesis of the hernia. So my idea was actually you used to have a closed abdominal wall, then your suture after surgery doesn't withstand the forces, and it slowly retracts and it becomes thicker and thicker and thicker. And this is why all the material's up, down here, and then I can pull it back. So I was quite clear that this must be true. No other way until we began treating children, because they were born with a defect. So they never had a retraction really. Or did they retract during their time in uterus? But they're very stretchy, and they're even more stretchy than adults. So I ask myself, why are women better stretchable than men? And I think there's a lot of non-mechanical stuff happening. We're treating at the moment a lady with an open abdomen after giving birth. I mean, you've got a hormonal complete change in this body, and I think ladies who gave birth a few times, maybe there's a memory of an abdominal wall of how much you can stretch. I mean, it's fantastic. There's so many thoughts after your talk, Ramana, that I get lost probably. So in the beginning, I was frightened. Yeah, I was frightened about erectile dysfunction because I just got very focal lenses on my glasses, and I thought inside the next problem I will have is an erectile dysfunction. And now you start off with such a topic, which I didn't expect. So I was sweating a bit. Then it continued talking about Kuhn circle. Kuhn sounds really German. I've never heard about it. So I really believe that what we're doing is working. And when I saw the Kuhn circle, I thought, shit, now I'm on the second place there with the facial traction, and then it goes further, and then they say, why are we doing it? And then they go, and then I'm going to be burned in a few years as well. And then, fortunately, I remembered Reef Stopper. And Reef Stopper is the only one who didn't die. For me, it's the only anatomical reconstruction of abdominal wall, and therefore it exists all the years. And it's the only thing that you can combine with all the other things without doing harm. And another thing that I really believe in is my old boss told me to do as much nothing as possible and don't destroy things. And therefore, I believe that peritoneal flaps are something I didn't know 5 years ago, and it changed my life. It really changed my life. And when I go to hospitals showing them how to deal with big defects, I change their lives because it is material which is there, which we openly threw away. And now I use it and it helps me. It helps me an awful lot. So now I'm really getting frightened when I have abdomens like today, where you explant a mesh and you don't have any flap. So I really have to think what to do. So I have to pull on anterior and posterior sheath, and I get forced to go away from my normal algorithm. And it works. And so we always develop further, and I really enjoy this community and all this deep thinking in hernia. And what makes me a little bit Indian, you can call me whatever time if you want to talk about hernia. And so thanks a lot to be part here. I really enjoy it.
I enjoyed hearing you being mentioned as a hernia expert, Gary.
It's so funny.
You
I'm,
don't know.
I'm, I'm a vascular surgeon. I'm completely lost in this field.
Now you
Right.
know more hernias than anyone else, I believe.
Exactly.
You have gone so many places and done so many wide hernias. You are a real hernia expert. Now nobody will trust you with vascular surgery anymore.
Yes, the bad thing is if someone asked me to do a vascular anastomosis, I wouldn't be able to anymore, but don't tell anyone. Yeah, so.
So, Ramana, most of these large hernias occur because of the open abdomen. I mean, there are various reasons for open abdomen. That's why these hernias have occurred. Can we prevent these edges from retracting so that we don't really get these large hernias?
So, can we prevent the edges from retracting at what stage? At the time of the index operation, at the time of open abdomen management, or when the hernia is evolving? The answer would.
All three. All three.
So, if you look at prevention, that's a whole different game, right? So, prevention, definitely, I would say, when you're talking about normal laparotomy closures, everyone kind of agrees today that the short stitch technique works, which is 4:1 ratio using 2O PDS kind of material. And that's okay, but then realize that the short stitch technique works for elective midline operations in non-obese patients. Now, evidence is coming up on extrapolating those to other hernias, but it's not really for your lateral flank incisions, right? So we really don't know exactly the way of preventing flank incisions. Yes, you could say if the patient is obese, then I would put in a prophylactic mesh. Now, the Europeans have been trying to indoctrinate us on both these things, the short stitch technique and the prophylactic mesh implantation. They're not succeeding beyond their little bubble, because who puts in meshes in laparotomy closures? Very few people. I mean, I'm not saying you shouldn't put it. Of course, I'm not saying that. But I'm saying that in communities, surgeons still don't do it. So that aspect of the prevention is neglected. The other thing is, if you're talking about open abdomen retraction, this is huge. So I do have some experience, though limited, not as vast as some people, with the management of open abdomen. The key thing is to close the abdominal wall as soon as possible. The problem with all the various techniques that we've been using, say you've had GI anastomosis breakdown, peritonitis, re-explorations, washouts, and now the edges are wide apart, the bowel is outside, and so you don't know how to close. And the more you wait, the harder it is to close or impossible to close. And the abdomen gets frozen as well. So this is where using Botox at the time of detection of an open abdomen, possibility of an open abdomen, is absolutely important. So inject Botox when you have a septic condition and you're going to go back to the theater to wash out that abdomen. So I would say inject Botox and then use fasciotens, which is a different device, not fasciotens hernia, but fasciotens abdomen, which helps you to close the abdominal wall very quickly. And again, management of hernia, once it happens, and prevent it from becoming a giant hernia, operate early, get weight loss done as much as possible.
So Indians are very innovative. So I'm surprised that nobody has come out with like the residents pulling the margins or the edges for maybe half an hour. I understand it's a graded traction, and actually an exact traction is given. Are you aware of somebody who's tried that and succeeded or
These
failed?
things have been done by many people. It's kind of like operating in the gray market. So it's all under shadows. So it's really not replicable or teachable. But you can try what you want as long as you're able to help the patient close the abdominal wall. That's fine.
Diplomatic. Okay.
No, no, not diplomatic. That is real. That is absolutely real. That is how it is. You can't force people to use new technology. You can't force people to change. But if they say that they are happy with their practice, I think it's absolutely fine to let them be and let them evolve at some point in their own careers. So you can't force that change on people.
So actually, I was also a skeptic, but when Garion came to our place and showed this, I converted. So maybe more people need to actually see how it's done and the results to
I'm
realize.
telling you what will change the game. The game will change when the Americans start adopting it and start championing it, and this will be the best thing since sliced bread. Okay, so then it will be like the world's greatest invention, and that is how it's going to evolve. My prediction.
Quite true, quite true. Dr. Kalpesh, you have some comments and questions?
Oh, no, Kasai. It's a fantastic discussion. The only interesting paradox about the Kuhn cycle that Ramana was mentioning is that the last phase of any Kuhn cycle always becomes the first phase of the next Kuhn cycle.
Correct, absolutely.
Never said that.
There is an external influence which triggers the next cycle.
Yeah. So at least this looks a very interesting technique, and I think, as you very rightly said, that we cannot be dogmatic. I mean, we have, as an AWR surgeon, you have to be open to all the ideas, anything that helps you close the abdomen. So you should have the tissue traction devices in your armamentarium as well as the peritoneal flap technique in the armamentarium. Probably use them depending on the patient and the indications and the finances involved, everything. So I think it should be a win-win situation for everybody rather than being exclusive that, okay, I'm going to do only this and I'm not going to touch that. That doesn't really work. So fantastic, I think. And Radip, we have just about crossed 1.5 hours, 1 hour, right? And so that was a fantastic discussion. And if there are any closing comments, otherwise I'll ask you to do the honors and give the vote of thanks. I think Roshan had to leave because of something.
John, when do we expect US FDA approval? So it becomes. When do we?
Don't put him in a tight spot.
All right.
He cannot comment, I think.
Girion, I think they are asking you, when do we expect US FDA approval for the Peshotans device?
I'm deaf on that ear. No, sorry, Vivek, I can't hear you well. Well, I did have a conversation with someone of FDA 2 days ago, so I hope it's not too long. And well, I'm sometimes afraid, but if Ramana is right, I will be very happy if that goes on.
So just for my information, for India, do we need any now? Does the device has to be approved by any authority, anybody? No.
It's approved. It's approved.
Have any?
Dr.
It's a very long and difficult approval process.
Approval part of medical device of Peshotans in India, and now it is approved by CDSCO or the DCGI for clinical use.
Sorry, who is it approved by?
Now the
Vivek, your voice is too low.
It is approved by the drug controller of India.
Oh, is it approved? Oh, it's approved. Okay. Oh, great.
So Ramana, what about giant inguinal hernias?
That needs another different talk for another day.
I meant facial traction for giant inguinal.
Yes, I do know. Yes, it is definitely an interesting aspect of management of giant inguinal. Sorry, Vivek, you're saying something?
You want to wake up another night at 1:30?
No, not particularly looking forward, but honestly, the discussion has been pretty exciting, and I don't feel as sleepy at all. And you know how much I sleep.
Right. Thank you so much. Radip, can you just wind it up and maybe give the vote of thanks?
Yeah, thank you. Thanks to all the moderators, the speakers. I'll come back to you again. But before that, we have some announcements regarding our upcoming programs. So yes, we have a flagship MSCon, which will be in Jaipur from the 28th to 31st of August. So after DI surge, I suggest everybody does register for the MSCon. We have the Massey Lens program, which is a live online telecast of the various different surgery. This time it's on mini gastric bypass by Dr. Om Tantia. This will be on 20th of February at 7 p.m. And the next MRC online CME will be on locally advanced rectal tumors with involvement of pelvic bony structures by Dr. Chenikovsky, who's from Moscow, Russia. We have started the MMAS series all over India. The first MMAS colorectal will be in Aster Medicity, Kochi in March, 24th to 26th of March will be the online component, followed by the physical component on the 28th to 30th of March. Please do register for it. And the HPB, which will be the second MMAS course, which we are having from the 31st of March to the 6th of April. The course director is Dr. Biju. And the MMAS hernia, which is one of the very successful MMAS programs which we are holding, which is in May from the 26th of May till the 28th of May. So this is a change from the 23rd to 25th will be the physical meet and online will be after that from 26th to 28th. This will be in Jaipur. Thank you very much. In the end, I would like to thank firstly Dr. Ramana. It's beyond 2:30 a.m. there now. And I hope he can get up on time and really go about his job. Thank you very much, Dr. Ramana, for sparing your time.
Thank you,
Dr. who had to readjust his schedule just to accommodate us. He had promised definitely that he'll be able to take out 1 hour. We have gone slightly above that. Thank you very much, Dr. Girian, for sparing your time. We really love to have you on this meeting. Dr. Vivek Bindal, one of the leading robotic surgeons in India, done a wide variety of cases, especially hernia surgery. Dr. Vivek, thank you very much for coming on. And Dr. Yusuf Afaq, he is at AMU, Aligarh Muslim University, associate professor there. And he's one of the major proponents of peritoneal flap techniques. He's published a lot on the peritoneal flap techniques in all over the world. Thank you all the moderators for coming. Dr. Sarfraz had to leave in between, but yes, all of us know Dr. Sarfraz. He's the president of the Indian Hernia Society also, and very, very much active in hernia circles. I would also like to thank all the EC members and Meryl for supporting us throughout for the online CME. It's been 2 years now, more than 2 years, which we have been holding the CME. And thank you, Meryl, for helping us throughout. Meryl, if you would like to show some video, you can show it now. Thank you, everybody.
Thank you to everyone.
What was a visionary dream has now blossomed into the realization of a globally renowned medical device powerhouse. What evolved from a modest beginning now operate one of the most cutting-edge facilities in healthcare. What once was a single venture has now proliferated into a presence in 6 distinct domains. What began as a modest collection of products has flourished into a portfolio of over 200 diverse products. What was conceived in one country now operates through more than 150 nations. What started with a few inspired individuals has burgeoned into a global team of over 10,000 plus dedicated medtech professionals and underwent an evolution, experiencing substantial growth to emerge as a dedicated brand poised to address the healthcare needs of this world. All of this made possible through achieving comprehensive excellence in all domains. by embracing modern innovations that enable to win the hearts of healthcare providers and patients across the globe. The progressive transformation of the infrastructure has seamlessly mirrored the pace of technological advancements, culminating in an unparalleled achievement of elevated output and precision in production, setting an extraordinary standard within its niche. Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Myris, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Introducing Merrill hernia portfolio. ITAC A. Apsimesh. Merigro mesh. Filaprop mesh. Filaprop mesh soft. Marinium mesh. Profound N. Profound A. Mesic energy device. Mesic compact ultrasonic. Mesic laser. Mesic ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create more to life.
So thank you, everybody. Thank you very much.